So oxygen deprivation, this is a very, very high yield lecture both for step 1 and for real life, so super high yield. So we're going to go through a few terms first. Hypoxemia, as always, the emia means we're referring to blood, so it's low oxygen in the systemic arteries. That's hypoxemia. Now what is ischemia? Ischemia means there's inadequate blood flow to the tissue. So you can have obstruction of the arteries. That's a common cause of ischemia. Remember, like heart attacks, atherosclerosis, thrombosis, emboli. That all causes ischemia. Ischemia in the heart, in the lungs, in the brain. So that's ischemia, poor blood flow to tissue. Finally, hypoxia is low oxygen delivery to the tissue. Okay, so oxygen delivery depends on both blood flow and oxygen content of the blood. So hypoxia you can get from both from either ischemia or hypoxemia. Either of these can cause hypoxia, which is just a term for low oxygen delivery to tissue. So poor blood flow can cause hypoxia. Poor oxygen content in the systemic arteries can cause hypoxia. And then you can have other things that can cause hypoxia. For example, carbon monoxide poisoning. Remember, the problem here is that you have hemoglobin it's carboxyhemoglobin that's bound to oxygen, but it doesn't release it anymore. So even though you have the blood going to the tissue, the hemoglobin is not releasing oxygen, so you're getting poor oxygen delivery to tissue. You get aka hypoxia. Now I want to talk about causes of a hypoxemia. This is just low oxygen in the blood. We're going to talk about that. There's going to be 5 major causes. You want to know these, but like the back of your hand. And we could divide these into causes with a normal AA gradient versus causes with the increased AA gradient. So remember, like I told you, the terminology. A is alveoli, and the small a is arteries. So this is the gradient in their oxygen saturation. So if your lungs are working well, what should happen to your AA gradient? If your lungs are working fine, there's normal gas exchange, your AA gradient should be small. There's always a little bit. That's why we call it a normal one, which is from 10 to 15 millimeters of mercury. But if there's a problem with gas exchange and with equilibration, you get increased AA gradient. That is, your oxygen partial pressure in the alveoli is greater than your oxygen partial pressure in the artery because there's something blocking it from going to the alveoli to the artery. So let's talk about causes of a normal AA gradient. Remember, 10 to 15 millimeters of mercury. These are just basically when there's not enough oxygen in the air in general. There's nothing wrong with the lungs. There's not enough oxygen in the air or going into the lungs. High altitude, low levels of oxygen. Hypoventilation, poor intake of air and oxygen. So there's nothing wrong with the lungs themselves. You're just not supplying it with the needed resources to get enough oxygen into the blood. Now, causes of increased AA gradient that's over 15 millimeters mercury include VQ, mismatch, diffusion defects, and right to left shunt. I am going to talk about that all in a little bit. Let's talk about normal AA gradient first. So, high altitude. High altitude, we just look at this equation, it tells you everything, okay? The oxygen in the alveoli depends on inspired oxygen and then the oxygen consumption. It's the difference between inspired oxygen and oxygen consumption. At high altitude, your inspired oxygen is lower because the air is thinner, so now there's less air in the alveoli, and thus there's less air in the arteries because it just transfers from the alveoli to the arteries. Simple as that. Next, hypoventilation. Again, so causes of hypoventilation include opioid use, where you're breathing very slowly, COPD, just poor intake of air. So you get poor intake of air and thus oxygen, and so you get a decrease in alveolar oxygen, and thus, same idea, low oxygen in the systemic arteries, easy as peasy. Next is VQ mismatch, and specifically, for example, pulmonary embolism. Specifically, it's when you have more perfusion, so you don't have enough ventilation. So you have low V for Q. This is all ratio though, so you can have too much. For example, if you get a pulmonary embolism, when you draw a pulmonary embolism, it goes to the blood vessels, right? It goes to the lung vessels. This is a capillary here. This is the capillary. This is the alveoli. This is the alveoli, and these are the capillaries to the alveoli. So you have a pulmonary embolism here. You're blocking blood flow here. Blood flow can't come here. So remember what happens is this is gonna dilate. This area is gonna vasodilate. Because you're gonna shunt more blood to areas that Actually, this is poor drawing because I drew this for something else. But anyways, just imagine this alveolus fine, pulmonary embolism, no blood's coming through here. This side vasodilates, and so now you have increased blood flow. The ventilation here stays the same though. So you've increased blood flow. So this ratio is decreased. So you have all this blood that's coming through, but you only have so much air. So only so much air can go from the alveoli here. So you're not going to be able to completely perfuse all of this blood that we're shunting here. So you can get VQ mismatch. There's going to be lower oxygen here, and so that's why you get hypoxemia. That was a little not clear, so I wanted to show you a different example. And this would be when you have a mucus plug in your alveoli, and this is why this alveoli looks all scrunched up. Because the mucus plug prevents oxygen from going through. So if you're not getting oxygen in there, your alveoli is gonna collapse. Nothing's keeping it open, and so your blood. Let's say your blood's coming down. This is in the doesn't have oxygen yet, so it's blue. Doesn't get oxygen. There's no exchange at all along this alveoli. This alveoli here has no exchange. This alveoli will have exchange, so it's going to get red. It's going to get oxygenated because you can see this alveoli is perfectly fine. It's not shriveled up. So let's do some numbers. So let's say, just for example, let's say you have the PO2 of 40 here when it's deoxygenated. Once it gets oxygenated, let's just say it becomes 100. But over here, it's still 40 because nothing happened. Well, maybe we'll call it a little bit. So we'll call it 50, okay? What's going to happen when these two mix? Well, you're going to get a mixing of blood. And now your PO2, let's just say it averages out to 75. PO2 of 75, that's hypoxemic. There's low oxygen in this blood because it got diluted by this stuff. That's a VQ mismatch. It's due to VQ mismatch. There's no ventilation here. So we have perfusion, but we have no ventilation, so this is 0. So VQ mismatch, V over Q ratio is 0. Whenever VQ is 0, when V over Q equals to 0, that's called intrapulmonary shunt. As you can see, it's a shunt because the blood is passing through, but there's no ventilation at all. Causes of intrapulmonary shunt. There's a nice thing. Basically, anything in the pus, water, blood in the or atelectasis cause intrapulmonary shunt. Pus, water, blood, atelectasis. What do I mean by that? Well, if you have pus or water or blood in your alveoli, then you're going to get shunting. Let's draw that out. Let's say you have water. That's pulmonary edema. So pus would be infection. Let's do it over here. So let's say we have pus would be infection, water would be pulmonary edema, blood would just be a hemorrhage. So this is all this water in here. Is air going to be able to equilibrate? Air can't even get down here. Air can't get through the water, so there's no air in this alveoli. It's completely filled with water. So this blood is going to, let's see, this blood here, let's change color. This blood's going to come by, it's not going to get ventilated at all. There's no oxygen diffusion here because it's just water. So that's how you can get poor oxygen in this blood. This is an intrapulmonary shunt. So again, what are the causes of intrapulmonary shunt where your VQ equals to 0 because there's 0 perfusion? Remember, it's pus, water, blood, and atelectasis. Atelectasis I already showed you because you have something obstructing the alveoli, it collapses. Atelectasis is alveolar collapse. So that's it for the low VQ ratios. Next one is just diffusion defects. I told you this equation before. Diffusion depends on area and the diffusion coefficient of the gas as well as alveolar wall thickness. So things like emphysema, fibrosis, or pulmonary edema can all decrease diffusion. Emphysema decreases it by decreasing the area for diffusion. You may be confused by that, so I want to draw that out too. So this is a normal alveoli, and emphysematous alveoli is extra large, right? So you're thinking this is extra area, this extra area here. But if you want to think about area versus the volume, you have all this volume here, and you have area. So all this air in the middle is not going to be able to diffuse. So that's the diffusion defect. It's so much farther to diffuse. It has trouble diffusing. That's a diffusion defect. Fibrosis and pulmonary edema, what's going to happen? Well, fibrosis is it's alveolar wall thickness. You have fibrosis of this alveolar wall, and so oxygen has more trouble getting through. So that's diffusion defects. Finally, we go to right to left shunt of the heart. So right to left shunt of the heart. So we already talked about shunts in the lungs. So, but if you have a right to left shunt in the heart, let me just draw this out. Basically, deoxygenated blood from the right side of the heart, right side, bypasses the ventilated alveoli and just gets directly shunted to the left side. So this shunted blood is going to dilute to normally oxygenated blood. Let me draw that out for you. So from the veins, we have deoxygenated blood coming through to the right side of the heart. And you see here there's a defect in our heart that allows blood. First of all, heart normally would go to the lungs, right? But now we have a ventral septal defect, and so this deoxygenated blood can go to the left side of the heart, where it's going to mix with our oxygenated blood coming from the lungs. So we have oxygenated blood coming from the lungs, and they're going to mix. And let's just look at our numbers again. So oxygenated blood has PaO2 of 100, PO2 of 100. Let's say again it's PO2 of 40. So now these two are going to mix, and what's going to happen? We're going to mix, and what's your PO2? It's going to be an average of the two, so it's going to be PO2 of 70. And again, that's hypoxemic. So you're just shunting blood. It's a right to left shunt because it's from the right side of the heart to the left side of the heart. So a similar idea to the intrapulmonary shunt, where you're shunting deoxygenated blood away through the lungs and to the left side of the heart. Except for this one, it's happening in the heart itself. So that's our right to left shunt. So again, causes of hypoxemia in general, we can divide into normal AA gradient versus increased AA gradient. Normal is just you're not intaking enough air. It's either hypoventilation or altitude. Increased AA gradient, there's something wrong with the lungs. Either there's a VQ mismatch, there's too little ventilation in proportion to the blood flow, so the blood's not getting ventilated, it's not getting the oxygen into the blood. There's a diffusion defect. Again, there's not getting oxygen from the alveoli. There's a barrier to get from the alveoli to the blood. You have to know that equation. Remember, it depends on the area or the alveolar wall thickness can cause diffusion defects. And then finally, we can have right to left shunts in the heart that can cause it, because you can get this deoxygenated venous blood that goes from the right side and goes to the left side and then goes to systemic circulation, and now you have deoxygenated blood because it mixes. So that's it for hypoxemia. It's a very high yield lecture. Make sure to know all the causes of all the 5 causes of hypoxemia.